in September 2021, the State Capacity Initiative at CPR started a regular event series titled Know Your Regulators. Today, we bring you this series at CPR Dialogues 2022 with our next session, Know Your Health Regulators. Regulation of health is one of the most difficult areas of public policy. This agenda in India is delivered by a vast array of public agencies at the union and state levels. Each of these agencies is unique in terms of its regulatory mandate and the nature of challenges that it is set up to address. In this session, we explore the nature of regulatory activity in the health sector, covering the subsectors of public health and healthcare. Our stellar panel for this session is Rajesh Bhushan, Secretary, Ministry of Health and Family Welfare, Government of India; Dr. Balram Bhargava, Professor, All India Institute of Medical Sciences and former Director General, Icmr; and Secretary, Department of Health Research, Ministry of Health and Family Welfare, Government of India; V.G. Somani, Drugs Controller General of India, Central Drug Standard Control Organization, Government of India; and Dr. K.P. Krishnan, Honorary Research Professor at CPR and former civil servant, also the moderator for this session. Dr. Krishnan, over to you.
Thank you. A very good afternoon to my respected panelists, and a very good afternoon to all of you. Let me first thank CPR for this opportunity, and let me thank my panelists for being with us today. As was mentioned, the background to this conversation is a series of conversations that we've been having with regulators across sectors. The whole idea was regulation as a form of state intervention is somewhat different from other forms of intervention, and it's not a form of intervention which is fully understood. But as a form of intervention, it perhaps touches more lives than we realize. So we thought it was important that academics, practitioners, and the general public should get a sense of what is this form of intervention by the state, what are statutory regulatory authorities, and why is this important for all of us. And we've done in that conversation, the first of the regulators that we spoke to in great detail is a regulator that Rajesh, you helped set up, which is the Food Standards Safety Authority of India. And I'd perhaps not be wrong if I say that one public agency perhaps touches more Indians directly than any other public agency. Practically anything that we drink in a form of packaged edibles, things that we drink, including drinking water, etc., there is almost nothing that is edible that goes into us that's not regulated by FSSAI. And going ahead, we had conversations with a lot of the financial sector regulators, the last of which was with the pension sector regulator, Mr. Panda. So the idea was to now focus on a sector that has sort of, in the last 2.5 years, become so dominant that a lot of us know a lot of things about it, but may not be in the fashion that we need to know, namely regulation of the health sector. And with your permission, sirs, I'll just take a couple of minutes to explain the context of why we are focusing on regulation in the health sector, because health policy has a number of issues. And issues on which a lot of academic work has been done, a lot of research work has been done, but the sense was regulation in the health is not something which has been equally well understood. One would assume that the standard reasons for regulation, as outlined in economic theory, namely market failures, and therefore calling for state intervention, would be the starting point in the health sector also. In the health sector, looking at the public health component, the large areas of intervention by the state typically relate to public goods provision and dealing with externalities like vaccination. In the curative side, we have the standard classical problem of regulation that we see in the other sector, namely information asymmetry between the provider and the purchaser. I'm talking about private healthcare in this case, and concentration, which is power in the hands of the provider, which harms the consumer. This was the context in which Rajesh, Dr. Bhargava, and Dr. Somani, we decided to have this conversation. So without wasting further time of the audience, may I start, Rajesh, with you on the role of regulation in the health sector, particularly in the context of the fact that a lot of subjects in the health sector, as per the Indian Constitution, are actually in the state list, a few in the concurrent list. There is actually very little in the union list. Nevertheless, it's the union regulators, and I can go on counting them. Last count was 7 regulators already established, 1 more in the making. So we have a large presence of union, Government of India regulators in the space. So if you could throw some light on exactly what are these agencies, what do they do, and then I'll come to the next part of interface with the states. Over to you, Rajesh. Thank you.
Thank you, and let me first acknowledge that it's a pleasure to be here, particularly after the dull and drab work of, disposing of files. But today happens to be a slightly messy day, which I have told you as well as the other organizers. I won't be in a position to be here for more than maybe 45 minutes. So that having been said, let's come to the regulation part. You see, let's look at the Constitution, as you said. The Constitution says, as we all know, that health is a state subject. But it also says that there are certain very critical areas which are in the concurrent list. What are those areas? One area that was in focus in the last 2 years is cross-border transmission of communicable diseases. Now, this is something which we had never noticed, ever. But once we were dealing with the pandemic, suddenly a need was felt for a unified response, for standard operating procedures, for standard templates of who would be tested, how would they be tested, how would results be interpreted. And that is where my colleague Dr. Bhargav's role also comes in. And that is when, utilizing this provision of cross-border transmission of communicable diseases, which is in the concurrent list, Government of India decided that they would take recourse to the Disaster Management Act and notify certain authorities which in effect discharge the role of regulators as far as different aspects of dealing with the pandemic are concerned. So that's one example of the concurrent list. The other example is medical education, and that is what, again, a subject of the concurrent list. That is what has led to creation of Dental Council of India, Indian Nursing Council, National Medical Commission, which is the present regulator, which has come in place of the erstwhile, what was it called? MCI. Medical Council of India. And as Dr. K.P. Krishnan said, there is one regulator in the offing, the Allied Health Workers Commission. So that's another area in the concurrent list. Then one more area is vital statistics, registration of birth and deaths. This came into highlight because of this whole controversy on COVID mortality, where Government of India was standing on one end of the spectrum and WHO was on the other, and there was this debate where the Government of India said that there is already a robust statutory system of capturing birth and death, so therefore there is no need to take recourse to mathematical modeling. When you have actual real live data being done by a statutory authority, why should you be going in for statistical projections? So another area of concurrent list. But the basic question that you have referred to is, why is this so? What is the broad justification for the union government stepping into this domain? So that broad justification, and you yourself provided answers also, is one, information asymmetry, which all of us know, but far more than that, there are certain international commitments that sovereign governments decide to give. For example, the commitment of the global community to earlier the Millennium Development Goals and now the Sustainable Development Goals. अगर हम ये कहते हैं as part of our commitment कि हम फलाने साल तक टीबी को eliminate करेंगे, अगर हम ये कहते हैं कि there is something known as FCTC, Framework Convention on Tobacco Control, therefore I would have a statute which would, address this issue. How do I regulate this field? So that is where two articles of the Constitution, 252 and 253, become important. 252 broadly says कि दो या दो से अधिक राज्य अगर इस तरीके का कोई रेजोल्यूशन पास करते हैं कि फलाने एरिया में लेजिस्लेशन होना चाहिए, यूनियन गवर्नमेंट को करना चाहिए, तो यूनियन गवर्नमेंट कर सकती है. द प्राइम एग्जाम्पल ऑफ दैट इज द क्लिनिकल एस्टैब्लिशमेंट एक्ट, वेयर more than 2 states in fact passed such a resolution. Then there is 253, which says that if you are, which I have already referred to, that if you are as a country part of a international convention or a bilateral agreement where you have given certain commitments, and those commitments can be translated into reality only if you have a legislative framework, therefore you need to have a law. The classic example of that is the law governing HIV/AIDS, HIV/AIDS Act of 2017, and the Mental Health Care Act. So that was, what provided the leeway to the union government to legislate. So I think I'll stop there.
Thank you, Rajesh. That was very useful. I will come back to you on one point which flows out of the reference that you made to the National Medical Commission. Ordinarily, people familiar with regulation and who deal with the financial sector can understand this fetish with regulation and state capacity in the context of all powers being, for instance, an organization like SEBI does legislation, does execution of that legislation, and also does the equivalent of adjudication of disputes arising from a legislation that it makes and it enforces, completely contrary to principles of separation of powers that we have known. Ordinarily, one won't assume that there is any such dimension in health, and we've just listed out, and I want to give one illustration before I move on to Dr. Bhargava. National Medical Commission, sections 10 and 57 of the Act of 19 give it powers to draw regulations on practically all aspects of medical education, institutions, medical researchers, medical professionals, and professional ethics in the medical profession. In other words, the substantive law on the subject will be written by this body. This body has executive powers with 4 boards constituted under the body to actually implement it, and it also has adjudicatory powers under section 10 to deal with appeals that arise from decisions that it takes. So I just want to make it clear that when we are talking about all of the standard worries that we have vis-a-vis regulation, namely concentration of powers in a state agency, but more important, capacity of the state agency to actually deliver on all these sort of matters on which powers have been given, the question of regulation in health is as important as any other sector. With that background, Dr. Bhargava, number one, thank you very much, sir, to take time off. I'm sure this is coming at the expense of some patient who probably will have benefited much more by your time. But I think in the interest of sort of a larger public policy audience, if you can tell us about Icmr, because it's not a classic regulator, but it's a very important pillar of the entire medical regulation activity. So a little bit of context on what does this society registered under the Societies Act, and perhaps one of India's oldest research bodies, what does it do and how does it interface with the regulators?
So thank you so much. Thank you so much for calling me for this dialogues. Just want to emphasize that the Indian Council of Medical Research, as you mentioned, is one of the oldest research body, established in 1911, one of the oldest in the world actually. And it has about 28 top national institutes with several field stations. So it has a pan-India presence. Over and above that, it also has, as part of the Department of Health Research, Government of India, and under the aegis of Department of Health Research, there are more than 135 viral research laboratories, which served as the backbone during this COVID, actually. This was a vision of the earlier, my predecessors who set that up in 2010-11, and that really helped 10 years later, that we become self-sufficient on viral testing and surveillance and pandemic preparedness kind of a thing. So that ball was rolling since 2010. In terms of the role of this autonomous body, it really enjoys as the benefit of an autonomous body. It serves, it's not a regulatory body. It serves as an interface between industry and the drug controller. So it's something like, so whatever research has to be done, it guides the industry, it guides the academic institutions that this is the kind of research that you have to do, this is the protocols, and then once that is done, either through the Icmr institutes or the medical colleges, then those results are then submitted to the drug controller. Two regulatory agencies, small agencies, are within the Icmr network. One is the Clinical Trial Registry, which has a register of all the clinical trials that are happening. More than 14,000 or so have happened in India, and that is, they are tabulated, and you have to go through that for any clinical trial. And the second is the Ethics Committee Registry, which is also at the moment voluntary, but it is going to become mandatory in a matter of a few months, that any organization that is going to do research should have an ethics committee, and that ethics committee should have a member from the civil society, a member from the medical community, and others, and then notify that to the Department of Health Research. So that is pretty much the role of Icmr, but basically it has three major elements. One is that we have invested in infrastructure, human resources, and research and collecting data from different parts of the country on different diseases over the years. We have also had the role to play in communication. And communication with, for example, in the COVID-19, what is the problem with stigma, vaccine hesitancy, taking the community along, that was communication. And the third thing is collaboration. So all collaboration with various institutions, medical institutions, scientific bodies, as well as international collaboration. So the Icmr, because of its long history, has quite a good capability of convening people. So that is another point that is leveraged and is utilized for regulation for various things.
Thank you, sir. That was very helpful. Before I come back to you, I'd move to Dr. Somani. Dr. Saab, we vaguely know what does the drug controller do, but we also know that there are drug controllers in every state. So given that there is an act that you administer, and given otherwise that a lot of us think that India perhaps is in an industrial sense, justifiably called the pharmacy of the global south. Despite that, medicines as a part of expenditure for an average Indian is still very high. So there are a lot of these sort of paradoxes that I want to come to. But before that, if you could explain the role of the Central Drugs Organization, the legal as well as the in practice role, the roles of the state agencies, and given that we are now as a society not only concerned with medicines as we understood them in the past, but a whole lot of devices which are perhaps diagnostic devices, increasingly, things like wearables, which are beginning to have medical connotations. And I remember reading in the newspapers that the new act, which is in the making, the Drugs and Cosmetics Act, perhaps is going to cover all of those instruments besides medicines. Could you throw some light on the role of the agency vis-a-vis states, and on a number of other issues that follow?
Thank you, Chair, and thank you for calling in this very important function. The drug, as you started, falls into the concurrent list as such. And drug by definition, includes vaccines also, diagnostics also, immunotherapeutics also. We, when say that it falls into the concurrent list, it is regulated by state and center. And there is some of the responsibilities which are mutually exclusive and some of the responsibilities which are mutually inclusive. And as Dr. Rajesh sir have already told, when it comes to the international borders, because it's not that only we make the drug and we consume our own drugs. We get the drug from outside also, many of the drugs. Because in the beginning of our independence, we were the importing country. So whenever international border comes, the role of center becomes very important. Their individual state cannot handle that situation, and they do not have that much of wherewithal also. So the manufacturing activities, regulation of the manufacturing activities, sales, distribution, that is sales in the pharmacy outlets or the medical store depots, or distribution, these are primarily regulated by the state regulator. And regulation of the medicines with regards to its quality, safety, efficacy is extremely important. The supply chain has to be totally secured and its integrity has to be maintained. It's not that, anybody can sell anything, proper personnel. So manufacturing, sales, distribution, and if there are certain malpractices into that, to take preventive actions like sampling, testing, and also corrective actions by taking the quasi-judicial action, administrative action, or prosecutory action. That is the primary responsibility of the state. Then what does the center does? Center, as a central drug regulator, for example, any new drug is to be introduced into the country for mass utilization, whether it is a new vaccine or a new anti-cancer drugs, it has to undergo clinical research, discovery, clinical trials. So these clinical trials are to be regulated in a very strict manner with regards to its protocol, its ethical conduct, its endpoint, its statistical endpoint, and its results, and the decision based on these results. So this entire regulation of clinical trial, along with the quasi-regulator like the ethics committee at each site, is done by the central regulator. Then what is being imported from all over the world in our country, its regulation with regards to quality, safety, efficacy of those products, its supply chain traceability is also done by the central regulator. Pharmacovigilance, then helping the central government for making the regulations, amendments into the regulations, and overall surveillance. And then there are certain responsibilities which are joint responsibilities of state and center. Very critical products like vaccines, blood products, salines, these are regulated by state and center together as far as its manufacturing regulation is concerned. So, in brief, this is the structure, and all the states have state drug regulator. They have their officers into each district as far as and they have the laboratories also. Many of the states have the laboratories for taking the sample and testing it, and these are statutory laboratories. Central government also, we have the 6 zonal offices, 13 sub-zonal offices, and 7 laboratories which are capable of testing any kind of drugs. And not only drugs, we also regulate cosmetics and medical devices. Up till 37 categories of medical devices are under the regulation, but from tomorrow and the act which is going to come into the future, all the medical devices, low risk, high risk or medium risk, means if you have to say high risk medical device, cardiac stents, pacemakers, this comes into the high risk. But the tongue depressor, wheelchair, this come into the very low risk. So these are, and it's a very different kind of regulation than the drugs. It's because they are distinct from the drug, they don't, and immunodiagnostics, the diagnostics also. These are regulated by, mostly regulated by the center, and class A and B are regulated by center along with the notified bodies. So this is in brief about what does the central drug regulator and state drug regulator does.
Thank you. Thank you very much, sir. It's actually fascinating. Going back to the point that Rajesh, you had made at the beginning, we actually have in place a very sophisticated regulatory mechanism which, the original constitutional design, based on, my own understanding and what you said, clearly seems to have made a very logical, spatial incidence-based distribution of regulatory power. The moment something is India's interface with the rest of the world or something that is pan-India, clearly it is vested in the union, and something which is more regional or local clearly is vested in the state or below. So clearly there is, I think, coherent logic to it. We were to have Dr. Aruna Vanikar to have joined us today. She is the president of the Graduate Medical Board in the National Medical Commission, but for reasons beyond her control, she could not join us. So I'm going to take advantage of the knowledge of both Rajesh and Dr. Bhargava to also speak about medical education, because this is an area on which clearly there has been a lot of thinking in the government of India. The 3 or 4 sort of top of the head issues that I can recall: A, given that healthcare delivery is a very person-intensive activity, quality and quantity, given the large populations that we are dealing with, quality and quantity of trained medical personnel, doctors and allied health professionals is clearly important. And this has been a problem. The number one, the shortage. 2, the very sort of lopsided distribution of the available medical personnel. So on this broad topic and on the need for more as well as better medical colleges and quality medical professionals, what are the regulatory changes that we have brought about, and what are the regulatory changes that we are likely to see? Rajesh first, and then Dr. Bhargava.
I would divide this into 2 very broad parts, and then Dr. Bhargav, with his experience of having actively contributed in the earlier avatar of the present regulator, that is the Board of Governors of MCI. There was a BOG MCI, which was the interim regulator when MCI had been superseded and the new regulator had not come. Probably he would supplement that. But the bigger picture, why do you need regulation in medical education? You see, if you look at the numbers, roughly we have around 12.5 lakh allopathic doctors registered in this country. But let me also admit that that data is not very robust, because people who have migrated out of the country, their names still figure. This is a decentralized database which the present regulator is now trying to bring on a centralized platform. When I say decentralized, it means that state medical councils have these databases which then get aggregated at the national level. So roughly 12.5 lakh allopathic doctors, roughly 8 lakh Ayush doctors, roughly 10 lakh allied healthcare workers, which would include lab technicians, physiotherapists, nutritionists, optometricians, so on and so forth. There are 56 such categories of allied healthcare workers for which that new regulator would be stepping in. So, if you look at the availability of doctor to population, then obviously we are at a disadvantage if we take only the allopathic doctors. When I say disadvantage, it means that whatever is the normative standard which has been fixed by WHO, which is 1 doctor to 1,000 population, we do not fulfill that. So we need more doctors. However, if we add the Ayush doctors, then we have 1 doctor to roughly 830 or 837 of the population, and then we can say that we do have doctors. But the fact remains that you need more doctors, particularly those who are in the nature of general duty medical practitioners or GDMOs or family physicians. There are different nomenclatures across the globe for these people. So you need more of those. You need more of specialists and super specialists. That means you need people who have done MS, MD, DM, MCH. I have covered all. So you need those people also, because you may have young children with cardiac disorders. So what do you do with them? So you need these super specialities, pediatric cardiovascular diseases. This is just one example. So there are multiple such examples. So to ensure that the curriculum that produces these doctors, specialists and super specialists, that is of a minimum prescribed standard across the country, and the way the profession is practiced. So two aspects. आप क्या पढ़ा रहे हैं और वो पढ़ने के बाद आप क्या practice कर रहे हैं. Let me give you a concrete example. कई बार क्या होता है, whenever we talk of these concepts, they somehow do not sort of strike a chord. So when I say how the profession is practiced, that should also be regulated, and I am saying should. That should also be regulated. Suppose I am undergoing a medical procedure. Usually, आप लोगों ने देखा होगा, someone would come to you with one sheet of paper saying कि please sign this, or your attendant family person. That is apparently the informed consent. How informed it is, no one knows. If an experimental therapy is being administered, the doctor should ethically be telling me that these are the advantages of this experimental therapy, but it may result in death in certain cases. How many of us are given that information, and then we make a choice? So therefore, when this new regulator came into being, NMC, it had 4 boards. One was the UG board, the president of which was supposed to come here. It looks at what is taught to undergraduate students. As I said, कि क्या पढ़ाते हैं. Similarly, there is a PG board, कि जो MS, MD वाले लोग हैं, उनको क्या पढ़ाते हैं. उनके भी एक president होते हैं. Then the third board is ratings and accreditation board. If you have 650 medical colleges in our country today, which is the exact figure, both public and private sector, then you need to rank them, you need to accredit them, you need to give them approvals, you need to increase their seats, decrease their seats. So that function is done by this third board. And the fourth board is the ethics board. That is the most important, but somehow not very glamorous. People don't know of it. And this is the board which should be looking at complaints against professionals who have not practiced the profession in the way it should have been practiced. So these are the 4 boards, and that is how this regulator came into existence. One more thing before I part with this subject, that is that if you look at how this infrastructure of medical education has developed historically, you will find that there is a huge historical deficit north of the Vindhyas and there's a huge historical surplus south of the Vindhyas. The same thing exists if you look at northeast and rest of the country in terms of medical education infrastructure. The same disparity exists if you look at Himalayan states, Himachal Pradesh, Uttarakhand, Jammu Kashmir, Ladakh, and rest of the country. So that acts as a trigger for the union government to step into this space and say कि मैं बनाऊंगा medical college. And then the states may, take over the responsibility of running them, the recurring expenditure, because this is also a perennial debate. Why has central government stepped into this? आप क्यों कर रहे हो इसमें? हम इसलिए कर रहे हैं because there are historical deficits. और कोई भी सरकार रहे, irrespective of political leanings, they have to address these inequities. Thank you.
So I think you have said it all. I'll just add some philosophical aspects to this regulation. One point that I want the audience to think is that we are in a phase of transition between the traditional post-independence colonial medicine, which was more based on trust and patient-doctor relationship, to a more Americanized fee-for-service program, which is now glamorizing super specialists. Whilst the original concept which I talked about used to call those super specialists as subspecialists, subspecialty of cardiology. Although I'm a cardiologist, but it was subspecialty. And the key difference and the key thing is fee-for-service versus not for fee-for-service. Now, patient-doctor relationship is based on trust. And that trust is now being attacked by all kinds of forces, whether it be a pharmacist, a pharmaceutical company, or a lawyer, or a patient relative, or Dr. Google, or internet, or second opinion, or so there is lots of people playing around with that holy patient-doctor relationship. That is my first point. The second point I want people to think on is that human biology and patient medicine is a stochastic science. And the mindset of people in society today is deterministic. Because of so much of internet, mobile, computer, they think everything is binary. In medicine and in human biology, there are gray areas. And once there are gray areas, either one could be messing around with it, whether it is the patient or the doctor. So regulation is important. And regulation has been there traditionally for and various agencies, as Sri Rajesh Bhushan has mentioned. And I think the good example is the General Medical Council of the United Kingdom, which has a system of an ombudsman, where the register is very strictly maintained. People can be struck off the register for some time or forever, and that little kind of a sword is hanging on every physician's head. That ensures quality of the doctors and quality of communication with the patients, so that the patients do not realize that they are being cheated or not treated well. So that communication is very important. And this is more important in two areas. One is ethics. Second is when we talk about breaking bad news to patients. And third is when you're doing various procedures and consent, and then end-of-life care. So these are various areas which can have a separate debate like this.
Thank you very much, sir. Given that I'm conscious of Rajesh's 5 o'clock departure, I thought the audience should have the advantage of being able to ask you questions before you leave. So if you permit, I will break the flow here. I have a lot more questions that I need to ask Dr. Somani and Dr. Bhargava. But in the meanwhile, we have 10 minutes where I thought, in case there are questions that we need to ask Rajesh before he leaves, floor is open. Yeah, I can see a hand there. Yeah.
Hi. So I've penned down a number of questions, and so when I was looking at them, they all seem to center around, a central theme. What I see in India is, and you have alluded to this, each of you, but what I see is a lack of, whether it's clinical ethics boards across the country, a lack of standardization because there's not a centralized control, or whether it's, paramedical training. There's a vast range of quality between, just take emergency medical technicians. If you're left alone in an ambulance, an ALS, there's a huge disparity in the level of skill that you offer because there's no centralized training. And same with clinical trials. Each entity has its own board, and you alluded to this, that it will become centralized, which is great. But I've dealt with a number of the boards, and they're left at the discretion of that entity, and they're usually private entities, so the quality is questionable at best. So are we moving in that direction where these things can be controlled, like the quality, there's a base level of standard quality from, that can be expected in all these areas? And, specifically also the supplemental treatment market, the herbals that have come in, the muscle building proteins that have come in, completely unregulated. So my questions really center around that.
Thank you. Is there any other question? Yeah, Mr. Rajesh, no? Yeah. We'll take two.
Yeah. Many years ago when India faced a shortfall of engineers, engineering education was open to the private sector, defining the standards. So there was a flush of engineers coming in from states like Tamil Nadu and Andhra Pradesh. With one masterstroke, engineering education became open to everyone. And we are a nation of 135 crore people. Why are we facing shortages of medical professionals? Isn't it a paradoxical situation? Should we still control medical education and shouldn't we open it up, defining the basic standards that needs to be maintained so that we don't have shortages of any medical professional at all?
Thanks.
Okay, so can I answer before I forget what was asked?
Yeah.
Okay, so coming to your question, you refer to 3 specific examples. I'll take 2 of them. The third one, supplemental or nutraceuticals, I'll leave for Dr. Somani. The first issue of lack of standardization, whether it is a person who is supposed to be sitting inside an advanced life-saving ambulance, or even a BSL, a basic life-saving ambulance, and lack of standardization for clinical trials. While bits and pieces of it may be true, overall, if we look at our last 70 years history, things have improved. How? I will tell you. Let's take these technicians. As at the very beginning, I told you that for the last more than 70 years, there are 56 allied healthcare professions which were not regulated in this country. Whatever be the reasons, we won't go there. So what does this mean? This means that we were not regulating the way education was imparted, either to a nutritionist or to an optometrician or to an occupational therapist or to a person manning your advanced life-saving ambulance, nor we regulating how these persons would perform their duties or practice their profession. So this has been addressed now. And since it's a dynamic scenario, let's hope that eventually some kind of standardization would emerge as a result of states and the union working in a collaborative manner, and this regulator regulating these 56 professions. Clinical trials is something where we have progressed significantly. And today our clinical trials are at par with any other advanced country. Let's take US FDA. अगर मैं वैक्सीन बना रहा हूँ, suppose I am BioNTech or I am Pfizer, what is it that I am expected to do? One, I am expected to prepare a clinical trial protocol. That's step one. Am I right? So that clinical trial protocol is a sheaf of paper, which is based after consultation. You see, I am a company, I would have in-house R&D, मेरे लोग मुझे ये बताएंगे कि ये मैसेंजर RNA based प्लेटफॉर्म है, इस पे हमने एक वैक्सीन बना दी है, it works. But as a promoter, when I go to US FDA, the regulator, I go with that sheaf of paper, which is clinical trial protocol of how I would conduct preclinical studies, which is, my studies done on animals, small and big, which establish only the safety of the product that I'm trying to eventually get a market authorization for. And that sheaf of paper would also then contain how I would do phase 1, phase 2, phase 3 clinical trials, which will establish not only the safety, but the efficacy of that product on humans. And then US FDA would have a domain knowledge subgroup within the regulatory mechanism, which will then look at my sheaf of paper with a fine tooth comb and say that there are these deficiencies or this is okay. There are only two alternatives. And if it is okay, then they make their recommendation to the regulator, and the regulator then gives me permission to market either a regular market authorization or an emergency use market authorization. The only difference being that in emergency use market authorization, there would be emergent circumstances which are compelling me to give you that authorization, and I give it with certain qualifications. मैं ये बोल सकता हूँ कि तुमने जितने लोगों को ये प्रोडक्ट दिया उनका तुम पोस्ट एडमिनिस्ट्रेशन सर्वे करोगे, you would do a survey and you will at a regular interval share this information with me. This is how it works in US FDA, UK MHRA, Japanese regulator and the European Union regulator. It is exactly the same way it is working in India, at least for the past 10 years, if not more. And all this information for the first time, the regulator is putting in public domain. इनके यहाँ, suppose I am a promoter, I go with my clinical trial protocol, his subject expert committee, which will examine it, their minutes, if they meet multiple times, all those minutes are in public domain. Everyone can debate those minutes. So that rigor is there, and if the approval has been given with certain qualifications, they make it a point to ensure that if I'm supposed to give them information every month, every 2 months, every 6 months, I'm actually giving them that information. So that is as far as those two examples are concerned. The third, I will leave for Somani ji to respond. As far as your question is concerned, it was on making medical education free as was done with the engineering education. I would not make that comparison because there are certain other issues there which are problematic issues. But how is opening of a medical institution governed? That is the question. And are we making it simple enough for people who have the money and who have the inclination to open a medical institution? They have the freedom to do so. That is the question. That is what it boils down to. So when this NMC, the new regulator, in 2019 came into being, the first document or the first regulation that they produced is known as MSR, Minimum Standard Regulation, which says earlier there was, which is, at times it appears very funny, there was a regulation कि अगर आपके पास इतनी जमीन नहीं होगी तो आप मेडिकल कॉलेज नहीं खोल सकते, which is, the ultimate ridiculous condition to impose, because you can always go vertically up. So therefore, they did away with that condition. Today, if you want to open a medical college, no one will ask you, आपके पास 10 एकड़ जमीन है, 50 एकड़ जमीन है, 100 एकड़ जमीन है. No one will ask you that question. The second thing they did was, they said that you can have audio-visual lectures. For certain specialized subjects, we are not insisting that you must have physical faculty. So, over a period of time, the MSR from 2019 till date, it's been amended twice, they have simplified this. But I agree with you entirely that there are certain provisions which can further be simplified. However, something that must go hand in hand with this kind of opening up of the medical education sector is creation of opportunities for absorbing these people. We should not go overboard in opening a sector and produce professionals who then are not employed. Look at what is happening to dental UGs and PGs in our country. But that's, a matter for another day. So we must learn from that example, and we must simultaneously in the states create opportunities through national programs, state programs, where these professionals can be gainfully utilized. Thank you.
Any other? Is it a question addressed to Rajesh? Then I'll come back to questions later. So Rajesh, I don't want to hold you.
This one.
Oh, addressed to, yeah.
Sir.
Sir, as said during the discussion, sir, it's a market failure as you have mentioned, and then possibly the trigger for regulation, and then the transition from traditional trust-based to, the fee-based approach, market-related issues, and wherein COVID pandemic has shown the limitations of health sector. So, and then, as you said, state subject versus whether the center to be intervened or not. Then there was, you tried to resort to Disaster Management Act, but there was Epidemic Act 1897 also, sir. And given the transition in the whole health sector, sir, don't you think that this also should be amended suitably to encompass the, wherever the tooth is missing, that has to be brought into it? Because there was, even though the attempts are very gallant, but still the field reality has exploited the end user. And there were many instances where they are not, the grievance redressals are very short in a way. State-sponsored insurance schemes are also there to take care of the financial risk protection in the process. But Maharashtra could do one thing, that they could increase the cap, particularly for COVID, and the COVID-related packages were also included in the, state-sponsored insurance, so to accommodate the, empowerment, potential empowerment of the normal, even for the white ration card holders were also included in the, as a, but they have, because COVID era, the resistance was resolved and the resources were pooled. But it may not be sustainable over a period of time.
So, can you phrase the question, sir?
I understood.
Okay.
Thank you, sir. Multiple questions, huh?
You repeatedly handle Parliament, so you understand this business well.
No, I could at least phrase two of them because there are multiple questions. One is that there is a British era epidemic act, and there is a need to amend it. The second is that you need to, expand your social security cover. There are insurance models, there are trust models, not the trust that Dr. Bhargav was speaking between the patient and the doctor, but trust model as in the state stepping in and providing that pool of money for social security. As far as the first question is concerned, yes, I agree with you. There is a need. It was amended during the pandemic, particularly to address the issue of violence, physical violence against doctors and paramedic workers. And it imposed certain punishments, penalties, and jail term and so on and so forth. There is an ongoing debate where there are very sort of defined pro and con sides which say that India should have a Public Health Act, which should eventually, replace this Epidemic Disease Act. But I will stop there. The second issue of expanding the cover to provide health services, in 2018, the Union government started something known as Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which is for a defined universe of 10 crore odd families 50 crore odd people, which is roughly 40% of India's total population, they would provide cashless hospitalization. Something which is a much bigger, more ambitious and rather refined version of what was done in US under the famous or not so famous Obamacare. So that's one part which takes care of the lower half of the population. The top half takes care of itself. So that leaves the missing middle. For that, people are still working in NITI and in Ministry of Health to develop certain standard templates which would be agreeable to insurance providers as well as to various state and union government to then roll out. So that is what I would want to say, and my profoundest apologies, sir. I have to leave now.
Thank you. Thanks, Rajesh. Amrita, can you see? Thank you. I'll catch you today.
Again, I apologize. Huh?
Thank you. Thanks, Rajesh. So we have another 15 minutes or so, sir. What I will do is, the question that Madam had asked on those supplements and nutraceuticals, which is the unanswered part, and the initial point that we started with, namely, despite the moniker of the pharmacy of the South, this business of expensive medicines is something I thought we could come back to. So if you could address both these, then I'll come back to Dr. Bhargava and then throw the session open for questions from the audience. Over to you, sir.
Thank you. The question was with regards to the supplementary food or medicine kind of items, which falls into the domain of basically nutraceuticals. And for that, FSSA Act has come out with specialty medical food they have defined, and through that it is properly regulated. Sometimes it's advertisement and it's the standards and all those things. These are also being regulated through that Food Act. So if at all any component of drug is falling into that with regards to claiming or curing diseases, that such kind of things are regulated by the drug regulator. That's a one part. Secondly, when you said that despite being called as a South pharmacy of the world, the medicines are quite expensive. Primarily, our all entire government regulatory system, government system and regulatory system is focusing towards accessible, quality and affordable medicines. And all our regulations are made like that. If you see, whatever is available at 100 rupees or in US or regulated market, that is available at 1 rupee in our country. And if you go to the neighboring countries, even like Sri Lanka, Pakistan or wherever it is, Bangladesh, it is still 5 times or 10 times higher than our country. So by making the policies, by making various manufacturing units to come up with regards to active pharmaceutical ingredients, with regards to excipients and with regards to formulation and also the vaccines, because India is providing vaccines to 40% of the population of the world, and WHO, UNICEF procures it from the India, means the WHO procures it from the India, and same is the case with the anti-tubercular drugs and anti-HIV drugs. Why it is still expensive to our public? Yes, there are various reasons for that. I may not be the right person to address that, but definitely, as far as to maintain the quality and make the drug most accessible and affordable, the government policies, including the regulatory enabling, so that maximum number of API and manufacturing units and researchers and developers, that develop in our indigenous capabilities, that is being taken care of. Thank you.
Thank you. Thank you, Dr. Somani. Before I turn to the audience, sir, I had a question, and this is not going to be on regulation. Given what we saw during the pandemic, clearly the ICMR was at the forefront, particularly because I recall your words there. The world was living with something that was completely unknown. Could you, sir, briefly tell us the ICMR's learning in handling this kind of literally a once-in-a-lifetime crisis and going ahead? Have we internalized these? Any advice that you have before I throw open the session for audience questions?
I think if I were to just summarize it, I would say the learnings from this pandemic were self-confidence. As an organization, as a scientific community, as an Indian citizen, we really developed self-confidence. That was the major thing. And the things that we did during this pandemic were, no one knew about this virus in the very beginning. So the pandemic was 3 months late as far as India was concerned. It had already taken over a lot of Italy, UK, Spain, Iran, so there were learnings from those nations. So what our policy at ICMR was to keep the door shut and keep the windows open. Let the knowledge come in. We distilled that knowledge and took decisions which were relevant for our country. Whether it be scientific things, whether it be starting from the isolation of the virus, to increasing the testing capabilities, to increasing manufacture of PPE kits, and it was a whole of government approach, manufacturing of masks or drugs, or the Covaxin or the Covishield, the vaccine, testing them in India, and then the CoVIN app we all know about, and then the supply of vaccines by drones to Northeast, first time in the world, to different parts of the world. So these were pretty much the learnings that we had during this, and ultimately it just boils down to self-confidence that we have the science, we have the caliber. Only thing, we have to exert ourselves. Traditionally, there was a perception there is lack of funding, but there is enough funding available for research within the scientific community in the country. We have to rely on that, and we also had this mindset that we have as a nation, that we believe in frugal innovation, low-cost innovation. And that mindset, which every Indian enjoys, whether it is genetic or not genetic, I think should be nurtured as long as possible. And it is being jeopardized as we are becoming more and more global citizens with more and more technology, more and more internet. So a piece of paper which I would not waste, now we don't think about it. So that mindset, probably we are more innovative and low cost. So those are the things which we were able to leverage in our country. It's talking about the drugs being expensive. I would say medicines are probably the cheapest in this country as you compare it to any parts of the. Yes, out-of-pocket expenditure is more because the national average is low in terms of this thing. And I would give just one example. For example, blood pressure medicines. We started a program called the Indian Hypertension Control Initiative. It's spread across 138 districts. We've treated 3.4 million patients treated about 12% of our population of hypertension of this country. Within a span of 4 years, $2.5 per patient per year is the cost of treatment. This, from the West's perspective, is unimaginable. And I think that is something to be really elated about, and I think we should carry that forward.
Thank you. In fact, I wanted to go back to your repeated references to Dr. Google and Internet and steal a phrase that you gave me at tea time. I learned a new phrase from Dr. Bhargava. He complains about what he calls the Indian digital obesity. I think it's a lovely expression for what a lot of us see. But you had a question, ma'am, and thereafter, if there are questions, we have time for a few.
My question is to Dr. Somani. So you stressed about manufacturing practices. Now we do know that the WHO has submitted its report to CDSCO about the inspection which was done of the Bharat Biotech facility in March this year. Inspection, which eventually, unfortunately, led to suspension of supply of Covaxin to UN agencies, and the suspension still continues. So the WHO has said that the report has been submitted to the CDSCO. So if you could, tell us particularly from a regulator's perspective, what were the loopholes that the WHO and the CDSCO joint team found? And a correction plan has also been submitted to the WHO, which has, at the moment at least, not been accepted by the WHO. So what is the way forward? So A, what were the loopholes found? And now, since the correction plan has not been accepted, what's the way forward for Covaxin as far as WHO is concerned? And if at all you are thinking of, putting these reports in public domain, since they concern public health at large. Thank you.
Any other question?
When it comes to regulation, there is this perception either the regulator is without teeth or it doesn't bite. So when it comes to health regulation, I think private sector is largely unregulated. It kind of overcharges and all that. We have seen that during COVID time. So we have on the one hand poor performing or non-performing public health sector, and then very high cost private sector. How do we address that? Where do we find the place for regulator here? That's my...
Hi, sir. I might be digressing a bit from the topic, but my question is that we spoke about regulations for public all this while, but I want to know what steps have been taken to involve tribal communities into these regulations, because they are also being affected by climate change or whatever urbanization is happening. So how are we dealing with that?
Which community? Sorry, I couldn't-
Tribal communities.
Tribal communities.
The question which was asked about this manufacturing of the Covaxin. As already explained earlier, that we have during the pandemic done starting from our scientific community, our manufacturers and our experts panels and regulator to find that we have a vaccine, indigenous vaccine in our country. And it was required at a scale which is unimaginable in our country. So with regards to when these vaccines were being manufactured at various scales, so whatever capacities and capabilities were there with the manufacturers, they were utilized and they were expanded also. In this expansion, there are certain upgradations needed with regards to the plants which are already available, and these particular aspects are being taken care of in the form of corrective and preventive actions, as has been asked. And sometimes when you have to expand the facilities or build the facilities or bring a new closed system or something like that, it takes time. It doesn't happen overnight. Even if you have to simply change your ventilation system, it takes, for building itself, it takes 3 to 4 months. Even if you do it faster, then its validation takes further 3 to 4 months. So such kind of things are there. Therefore, corrective and preventive action plan cannot be accepted in overnight. So it takes its own time. And that's how our regulatory system do work in this scenario. And second question was probably with regards to that I would...
Okay. So I think the second question is regarding private hospitals being not overcharging and not being regulated. So I think if I were to request you to give a definition of regulation, because regulation is perceived as something ominous, and that is what you want. Could you define that?
Sir, in the traditional sense, regulation is state intervention primarily towards a particular form of behavior modification. So, in the infrastructure sector, typically when there is a monopoly and you're trying to solve the problem of monopoly or concentration of power, there are price caps, there is price fixing. But in an area like healthcare, particularly curative healthcare, ordinarily the expectation is competition will take care of pricing, regulation will take care of quality. So if I'm a doctor claiming to be treating a patient, regulation will ensure that I'm indeed a doctor, I'm qualified to treat the patient. Regulation in this case is not explicitly, it is not taking care of how much you charge me. That has been left to the market. So in a sense, it can't be said to be a failure of regulation, the overcharging bit. If I've understood your question right.
I think you have answered my question to that gentleman. However, I would like to add that under the National Health Authority, we have more than 1,200 packages, which is a cap for payment for a particular procedure. And large number of these private hospitals which are responsible for 70% of the healthcare in the country, having 90% of the doctors from the country are in private sector, having only 50% of the beds in the country are utilizing this facility. So that is what I'm trying to say. In this, the private sector is paid by those packages which are price capped by the government, and any of these hospitals who are part of the PMJIY program will be getting only that much money.
Sir, do you want to briefly address that question about stakeholder participation? Though it was specifically on tribals, I assume a lot of the activities in this sector also must be, the regulations must be preceded by an extensive consultation process where I recall a lot of the drug controllers' instruments are put out for public consultation, and it's only after consultations are completed, and very often the complaint is very few people actually participate in the consultations. Though papers are put out, you seldom get comments. So I guess that is the context in which the question was asked. Specifically on tribals, I'm not a person in the sector. You may have a better sense.
I think every decision that is made by whether it's ICMR or Department of Health Research or any government body. For example, we passed 2 acts recently, the Assistive Reproductive Technology Act and the one more act for surrogacy. So there was enough public consultation from different civil society, from different agencies participating in interministerial comments, and then beaten the hell out of in the parliament before we came out with that act. So from that perspective, I do not see that the tribal population is left out from the participation, whether it be at the electronic level or at the parliamentary level through their representatives, or through the government level through their people working in the government talking about that. So yes, there needs to be much more participation from the tribal population, but as far as the ICMR is concerned, and the various treatments and the researches and the tribal population having different diseases is taken on priority, and we do have a tribal research forum which is looking at the problems of the tribal. There is an excellent report submitted on the tribal healthcare recently last year by the gentleman from Gadchiroli. He has made an excellent report, and I think the Ministry of HRD has given that report, or the Ministry of
Tribal Affairs.
Tribal
perhaps.
Affairs Ministry has given that report, and that report has really mapped out what are the priorities in terms of the diseases, whether it be anemia or tuberculosis and other nutritional diseases which are more priority for those areas. And we have taken tremendous cognizance of that report in our action plan for the Icmr for the next 3 years. We've done that proposal.
Thank you, sir. Yeah, quick question. I'll conclude after you. Yeah. You can use this mic.
Oh, you can?
Can you hear?
Yeah, we can hear.
So I just wanted to know, see, during COVID time, several healthcare aggregators had come up. It falls in the gray area of law. So how is the government looking at regulating them? Is there a chance that they will be regulated because there are healthcare practical lot of them, and their lab reports are also, like they call it AI, when actually a doctor should be signing it. So how does the government look at this? Or the regulator look at this, not the government, the regulators? And what can be done?
Would you like to comment on it? After I, okay. So typically I'll give you an example, pathology reports. Earlier it was not mandatory for the doctor to sign it. But now it is mandatory for an MBBS doctor to sign it. Here again, I'll come back to what I had said earlier, the typical mindset that it has to be signed by our specialist. We need to go down, and an MBBS is a great degree, and an MBBS is a double bachelor's degree. As per the law, an MBBS doctor can even do cardiac surgery today. If he is well trained with a cardiac surgeon for 3 years or 5 years, he can do it, but he still has that MBBS degree, and he's allowed to do that. But our mindset is, bhai, ENT ko dikhaya ki nahi dikhaya? A good surgeon or a good MBBS should be able to do that. That is where we have diluted ourselves in a big way. And if we start regulating it, it will make matters worse. The online, I'm talking about this as far as these physicians are concerned. In terms of these online Practo and 1mg, I think they are something which needs to be looked at more seriously, clearly. Particularly, they have made things simpler for many people, elderly, getting their medicines with electronic prescriptions. But the world is moving towards telemedicine, electronic health records, electronic communication. So getting medicines through them. That brings us to the drug controller, and he can talk about what is the schedule of the drug, Schedule H, Schedule Y, Schedule which should be allowed, and I think some of them are and some of them are not.
But not just drugs also, the fact that you can't advertise online. You can't advertise, but all of them go advertise. It's a grey area in the law.
It's a very grey
because
area.
They call themselves healthcare aggregators when they are not aggregators. They are selling it themselves.
True.
So
I would like to agree with you.
Dr.
Please do
Somani?
agree and do something.
Yeah, certainly this is the area where, since these are the newly developed areas, where our machineries, what we know, starting from the basic conceptual clarity with regards to how to regulate them, and also the cyber investigation if required in such cases. All these are the areas which needs to be developed, and certainly there is a lot of and these are the technology which are going to come into because they have their advantages also. They make life easier for the people. Instead of personally going somewhere and getting the things done, people have many hesitations. So they find this as a very easy and handy solutions. But easy and handy solutions are more secured, are more tightly regulated. That's what we expect, and that should happen very very soon in our near future.
Thank you, Dr. Somani.
Just stopping is not, maybe not be a solution immediately.
Yeah. So let me try and end this on a positive note. By definition, in a vibrant society, markets will always be 2 steps ahead of regulation. I think that is the path to development. Look at the financial sector. All of what we called financial aggregators and fintech, it's taken a while, but the Reserve Bank of India has come back and said, we go back to the fundamental question of consumer protection. If you are making a loan, then you are an entity that I will regulate. So I think it'll go back to basics, and we should also be realistic about what can regulation achieve, and beyond regulation, what does an alert citizen, an alert consumer need to do. So I think in the interest of innovation, my personal preference is to allow this vibrancy in society to continue. And as Dr. Somani said, there are clearly some benefits that flow out of these aggregators. But like all other market players, these aggregators will be pushing the law, and they will be testing whether they are on the edge of the law or on the other side of the law. And it is the capacity of the regulator to be on top of this and hopefully be able to solve it. Let me now conclude the proceeds of this evening. Sir, one of the primary purpose of our Know Your Regulator series was demystifying the domain and demystifying the concept of regulation. And I think if I were to apply that objective, it couldn't have been a more productive evening. It was an excellent session. I want to thank Rajesh Bhushan in absentia, Dr. Bhargava and Dr. Somani for this very, very thoughtful and very sort of open and candid discussion on problems in health regulation and, more important, possible solutions in the area of health regulation. This is just a beginning, sir. And as I mentioned to you in our previous meeting, we are going to sort of take advantage of your acceptance of this invitation and come back to you with a lot more events, essentially with a view to demystifying this further. Thank you again, and may I request all of you to join me in giving them a big hand.